And you have to wonder, if we'd had something similar, would his prostate cancer be picked up sooner?
Surely we're at a time when we're trying to save lives here. It's not about saving pennies.
New cases of breast cancer in the UK are occurring in the ages of 40 to 50. Breast cancer mortality is a lot lower. Why is that? Is it because we're only doing a mammogram every 3 years, 10 years after other countries are starting it? One guy was falling over and he still got chased and kicked by the other guy.
The guy kicked him in the bottom.
Yeah, it was brilliant. It's like almost like someone's pulled the rug from under my feet a little bit, because I've trained within the NHS, I've worked within the NHS.
Their aim is not to save the most lives. Their aim is to get the most bang for your buck. The reality, if you're really trying to give everybody the best chance, is different. Hello and welcome to another episode from The Doctor's Mess. I'm Dr. Nitin, and this is my co-host, Dr. Alex.
That's me.
They say that she's the doctor and I'm the mess.
That is what I've been saying, yes, for months now.
So we've been away for a while, all summer, in fact. And I think it's because we've been very busy. But a lot's happened since then. We have a new government.
We do.
We had the entire Olympics and all the other sort of sports that go on over the summer. And we had some birthdays.
We did.
And we both have new job roles.
We do.
So tell me a little bit about what's been happening with you.
Like you said, we've had some birthdays. So I had quite a big birthday at the beginning of summer. I turned 40, which has taken a little bit of time to process, both kind of before my birthday and subsequently, because I still think in my head I'm maybe mid-20s, but every morning when I get up, my knees and my hips and my back,
There are a lot more clicks than there used to be.
I mean, everything sounds like it needs oiling these days.
Is this what happens when we get older?
I wasn't quite prepared for the amount of noises that that my joints make, but yeah, they definitely like to remind me that I perhaps don't have the frame of a 24-year-old anymore. But it was a nice birthday. We had a nice time, and I'm adjusting to the fact that I'm meant to be a grown-up slowly.
And we're now adjusting to a new government.
Indeed. We've just had their first budget, which I think as a country, we're still sort of digesting a little bit in terms of what the implications of that is. And I think it might be something that we'll look at some point in terms of talking about the implications for the health service as a result of a change in direction.
I think it was really predictable that they were going to get in, because I think things had been really, really difficult for the last few years of the Tory government. Really, ever since COVID, things had been difficult. Obviously, we had the different scandals, and then we both know how difficult the NHS has been. And I think everybody out there knows how difficult the NHS has been, whether you work in it or whether you are a user of the NHS. You know how difficult it's been. I don't think I've ever seen it this difficult. So I personally am hoping that the new government can do something to improve things. And I guess we'll discuss that over time. They've just had the budget in which they've pledged 22 billion, which sounds like a lot of money.
Yeah, so it's 22 billion to NHS England. And obviously we have to always keep in mind when we talk about the NHS, although we talk about the NHS as a whole, when we talk about it politically, we're talking about NHS England from the government in Westminster, and then we have NHS Wales, NHS Scotland, NHS Northern Ireland, and so the pledge is for this extra pot of cash for day-to-day spending in NHS England. But I was looking at it, and I was looking at the most recent figures in terms of what the NHS running budget is, And when you work out kind of what their injection of cash is, it works out at a little bit over 6 weeks of extra day-to-day funding. Now, they're front loading that. So actually that's 6 weeks of funding over 2 years. But when you break it down like that and say it's 6 weeks, that actually doesn't seem a lot, does it?
So it's just an extra 3 weeks of funding a year.
Well, when you break it down that way, it's
not really a headline.
Well, that's why it's not the headline, is it?
It's barely pocket money. So we'll watch and we'll see what happens. And obviously we all hope that things improve, but we'll see whether they do.
I think, as you say, I think the election was really about public services. Obviously, because we're medics, the NHS is the natural thing for us to kind of focus on, and because we know about how it works, we know about how it runs, and it affects our lives on a day-to-day basis. But I think when you kind of read the headlines and read different kind of things on social media, actually it was about public services, wasn't it? It was about the NHS, about schools and social care and things like that. So we shall see.
And one very sad thing happened over the summer, I think really just last month, which was that we had the diagnosis for Chris Hoy.
Now, Chris Hoy.
Yeah. I mean, he is obviously a hero in British sport. Mm-hmm. And very sadly, he's been diagnosed with terminal prostate cancer. And he's only in his late 40s.
Yeah, so he's 47, I think. And from what I understand, he presented with shoulder pain whilst he was weightlifting, and went to whoever his medical team is. And a scan subsequently demonstrated a tumour within the shoulder, which was then found to be from a prostate primary. So he has metastatic prostate cancer, but yeah, very young.
I was having a read about this, and I saw that both his dad and his grandfather also had prostate cancer.
That's what I read in like his initial kind of interview. And I guess you then have to wonder, from my understanding is he didn't present with any kind of typical prostate symptoms. He presented with what is effectively bony pain. But you have to wonder if they're, based on his family history, would there be any opportunities to have picked that up sooner rather than later?
And that's the main topic for today's discussion, is screening. So if you start with Chris Hoy, so with his family history of both his father and his grandfather being diagnosed with this condition, then surely people should have been proactively screening him from a much younger age.
So in the UK, actually, like a lot of countries in the world, there isn't necessarily a formal screening program for prostate cancer. But the guidance in the UK suggests that men over the age of 50 should be counselled on the merits of a prostate blood test, so the PSA. So we'll talk about that in a minute. That is quite different, or it is different to the guidance or some of the guidance elsewhere in the world. And as we get through and talk about other types of cancers, we'll find actually there are quite a lot of differences when you start comparing our guidance to other countries. But I think when you look at the guidance in America, so this is the guidance from the American Cancer Society, and they suggest that men over the age of 45 who have a first degree relative, so someone like a parent or a sibling who has had a diagnosis of prostate cancer before the age of 65, those men should be counselled on the merits of prostate screening. And you have to wonder, if we'd had something similar, would his prostate cancer be picked up sooner?
I'll tell you what made me sad is that after he got diagnosed, I saw and heard a lot of doctors on social media dreading that they were going to get men come in asking for a prostate test because they thought, oh, this is going to lead to more work and there's going to be a lot of people who are the worried well. And that made me really sad, because the reason that people will come in is specifically to try and get some kind of screening for a condition that a percentage of them, and it will be a small percentage fortunately, but a percentage of them will have, even with no symptoms.
Yeah, so and I'm sure this happens in other countries, but in this country, we do see this a lot with celebrities, don't we? That we will have someone quite high profile who will speak out about a particular condition, and we'll tend to term it the XYZ effect, right? So for menopause, for example, we have the Davina effect, which is Davina McCall spoke very openly about her difficulties with menopause, with accessing treatment, with HRT, etc. Caused a massive influx of patients wanting to speak about potential perimenopausal or menopausal symptoms. And we call that the Davina effect. So we now have, in effect, the Chris Hoy effect, which is where men who may not ordinarily have gone to their surgery have gone, oh gosh, that could be me. Like he's a multi-medal winning Olympian. Like he's a hero in British sport. I mean, he has a knighthood, and he leads a life that you would say he was at peak physical performance. Maybe I should get checked.
In this country, we're still so focused on reactive healthcare, whereby we wait for something to go wrong before we do anything about it. Mm-hmm. And with all of the scans and technology available these days, then we really should be moving on to proactive healthcare, whereby we're actually looking after the future of our health. Mm-hmm. I think it's really time to elevate our healthcare.
So we've talked before about health screening and the potential benefits and the limitations of a public health system that is reactive rather than proactive. But in this situation, what should men be doing? What should men be getting checked? What age should they start getting checked? How often should they get checked?
Honestly, if it was up to me, you look at the data, okay, and that's one thing. But if it was up to me, I would suggest that most men from the age of 40 to 45, depending on their sort of family history, would start looking at getting a yearly PSA blood test done. Mm-hmm. And that is about as much as I would recommend at this stage. Mm-hmm. So if that happened, yes, right, other healthcare professionals are right. There will be plenty of sort of false positives get picked up, plenty of people that get worried about nothing in the end. But I guarantee that if you do that, you will pick up some patients with prostate cancer at an early stage, and it may be the difference for them between life and death. And I totally understand that that costs more money for the NHS, and it costs more money for all the different services that are going to have to look after them. But surely we're at a time when we're trying to save lives here. Mm-hmm. It's not about saving pennies.
I think it'd be useful just to talk a little bit about the PSA. So this is the blood test that you're talking about, though, in terms of what actually it's looking at. And because there are limitations, it's really not a perfect test. It's not a cancer test, is it?
No, you're right. It's not a perfect test. Essentially, a PSA gives us an approximate level for how big your prostate is. Mm-hmm. So most men won't even know what their prostate is. And I understand that. So let me try and explain. Essentially, the prostate is like the door between your bladder and the outside world. So it naturally gets bigger in every man as we get older. That's meant to happen. Mm-hmm. So we're fortunate in that there's a blood test we do called the PSA that gives us an approximate as to how big your prostate might be. So we expect that to rise through your lifetime. Mm-hmm. So as I said, your prostate will get bigger through your lifetime. So your PSA will go up through your lifetime, your PSA blood test. Mm-hmm. Okay. And what you're looking for is sudden changes in that PSA. If it suddenly rockets up, mm-hmm. that could give us an idea that something is not right. Okay. Or it could be that you start to develop symptoms of a big prostate. So if you imagine the door from the from the bladder to the outside world is bigger, then we get a range of symptoms related to difficulties sort of in urination, essentially. Mm-hmm. So we're talking about maybe going more often, having to get up at night to go, maybe a poorer flow when you're going for a wee, mm-hmm. And things like that. These are the kind of things that we're looking for. And if you start to get those kind of symptoms, then that's another reason to get your PSA looked at and to see your doctor.
So interestingly, I was looking at the history of the PSA blood test because I'm a little bit of a nerd and I was just curious as to how it was developed. And it was first approved actually as a monitoring tool for men who already had a diagnosis of prostate cancer, with the idea being exactly as you said, if there is a sudden spike or a sudden change in the prostate blood test, the PSA blood test, that indicated that maybe their disease was progressing and then something could be done about it. And then over time, as you move into the 90s, into the 2000s, that's when it started to become more of a, could we use this as a detection of prostate cancer? But I think it's important to say that, yes, prostate size obviously impacts the result, age impacts the result, but simple things like a water infection can also cause a rise in the prostate blood test. So I think it's always important, kind of regardless of the age of the patient, that there is a little bit of a discussion beforehand of what happens if this result is high. Are there going to be additional investigations needed? Will those investigations always be necessary? Because we know that actually not everyone with a raised prostate blood test has prostate cancer. So there is a potential that even if you have a raised level, you'll go through a series of procedures and investigations and it'll find that you don't have prostate cancer.
I guess from my perspective, at least you've been checked.
Mm-hmm. I don't know. I get that, but I'm just saying, I think it's sometimes when people come to us in surgery or in clinic, I think they think that it's a test for cancer. And it's very important that you have that discussion to say, well, a raised level could indicate something like prostate cancer, but it doesn't equal prostate cancer.
And there are some groups of men that I would definitely get checked a bit more closely. Mm-hmm. So we know that men of African descent mm-hmm. have higher rates of prostate cancer. And that's actually for a specific reason, which is that they have testosterone levels higher than the average man. Mm-hmm. So people of African descent have testosterone levels that are about 19% higher if they're compared to Caucasians, to white people. Mm-hmm. Okay. Other people that I would also be very careful with are anyone who has ever taken any form of steroids mm-hmm. in the past. And we know that maybe about 1 million young men in this country, obviously it's a guesstimate, are currently taking steroids. And, if that is the case, then that is increasing the risk for all of those men for prostate cancer. And I would recommend, again, that they are more closely checked than average.
So it's the elevated testosterone that's the risk factor.
So the reason that every man over time will see his PSA blood test go up mm-hmm. is that over time, our testosterone, the male hormone in your blood, mm-hmm. actually causes your prostate to get bigger. And that's natural. That's meant to happen. Okay. Mm-hmm. It's almost like an expiry mechanism in men, in that your prostate will get bigger over time. And if men live long enough, then we'll all develop prostate cancer. Mm-hmm. Okay. Whether you live to 150, you'll all get prostate cancer in the end.
Don't tell Brian Johnson that.
because of testosterone. Mm-hmm. So that's why the single most important hormone with regards to prostate cancer is testosterone. Mm-hmm. And in fact, one of the main treatments for prostate cancer is actually giving you medicines that completely turn off your testosterone. Mm-hmm. So that's why it's so important. So those groups are the ones that I'm probably more worried about. Athletes, people that are maybe taking excess testosterone, mm-hmm. especially obviously sort of bodybuilders and maybe pro athletes and so on. And then men of African descent because they have higher natural levels.
And those are the family history, I guess.
And then exactly, those were the family history. Mm-hmm. So I have no idea. I have no way of knowing whether Chris Hoy was checked more closely mm-hmm. because sometimes these things can be very, very rapid. Mm-hmm. But with a family history, as you said, of both father and grandfather, in other countries, he definitely would have been closely screened.
Mm-hmm. And I think kind of moving on from kind of male cancers to more female orientated cancers, although to be fair, it also affects men as well. But I recently had a patient in clinic who booked an appointment because they wanted to discuss breast cancer screening, so mammograms. And my initial gut reaction, because this lady was in her mid-40s, was to be like, you're too young. You're just too young to start thinking about breast cancer screening. Because in the UK, we have the NHS kind of breast cancer screening is you start you're called for your first mammogram between the ages of 50 to 53, and you will have a mammogram every 3 years for that period of time.
Yeah, we're all taught that sort of 50 onwards, really.
Yeah.
Right?
And so, I was giving her this spiel because I grew up in the NHS. I trained in the NHS. I worked in the NHS for a long time. They are the guidance that is kind of burned into my brain. So then the patient said to me, oh, but I read this from the USA. And I was like, I don't know about that. So that led me on to this kind of rabbit hole of looking at different kind of cancer screening programs across the world. And I was really shocked then when I started to compare what is recommended elsewhere in the world versus what is recommended under the NHS. So in America, the American Cancer Society recommends, and actually when I was looking at other sites in America, so like Johns Hopkins and places like that, it seems to be universally recommended that women consider starting their breast cancer screening journey, so mammograms, at the age of 40. And they are recommended to be annual mammograms, which is a full decade before we even think about it in this country.
So 10 years sooner and yearly.
And annually. And the reason for that was because 1 in 6 breast cancers in the US occurred in women between the ages of 40 to 50. So the whole point of bringing the breast cancer screening earlier was to capture this group of women. And we know, as with many, many things in medicine, early detection often leads to a greater range of treatment options, which often leads to better outcomes in the end, so better recovery.
So in the UK, we're not even going to pick up those, so what did you say, 1 in 6 cases?
So in the US, it was because there was 1 in 6.
Okay, so we're not even going to pick those people up unless they develop an actual symptom.
Yeah.
Or until they develop a symptom.
So then I started to look at the cancer stats in the UK to try and see, so if in the US it's 1 in 6 between the age of 40 to 50, what is it in the UK? The latest figures that I could find were from Cancer Research UK, and they're accurate up to about 2019-ish, I think, 2019, 2020, so pre-COVID. And there definitely is a peak of diagnosis kind of in the mid to late 60s in women. This is talking about women breast cancer screening, not male breast cancer. There is that peak in diagnosis late 60s. But I did break it down by different age brackets. So then I got really nerdy and started to calculate the percentage that are occurring of new cases that are occurring in women between the age of 40 to 50. And it's 16% of all breast cancers in new cases of breast cancer in the UK are occurring in the ages of 40 to 50. I was really shocked by.
So those cases we're only going to pick up late, really, when they've actually developed some kind of symptom or a lump or something like that, or obviously something worse.
Mm-hmm.
So this is the kind of thing that actually, I mean, it kind of upsets me, to be honest, in the same way that I had that reaction when I heard about Chris Hoy and other doctors were saying that actually, oh, this is a bad thing. Loads of people will come in asking for a PSA. As I said, those words that I said earlier, it's about saving lives, not saving pennies. And yes, it leads to extra work. It absolutely leads to extra work. And it leads to some people being investigated when actually they're okay. Okay. But we would much rather be carefully looked after and checked. And if you don't have it, great. Okay. Then actually it could have been picked up, but it costs the NHS too much money. So we'll just check you in about 10 years and see what's what.
The other thing I found that was quite interesting was, You know, I'm a particular fan of the Japanese healthcare system. I don't know why I've developed this particular fondness for the Japanese healthcare system,
It's because they've got the highest life expectancy in the world.
I every time I find a new fact out and they're like, oh, and it's Japan, I'm like, oh, figures. But in Japan, they have the highest rate of recovery from breast cancer. They also have one of the most proactive and aggressive kind of screening programs that start from the age of 40 in women. And you start to kind of see, like, what is there a correlation there between really aggressive, proactive screening at a younger age and actually far better outcomes? In the UK, compared to a lot of the OECD countries, we actually do quite well on breast cancer screening in terms of we screen more than a lot of OECD countries, but our breast cancer mortality is a lot lower. And you kind of have to start to wonder, why is that? Is it because we're only doing a mammogram every 3 years, 10 years after other countries are starting it?
So with Japan, obviously, I'd have to guess that because they're picking things up earlier, you're going to get better outcomes. Okay. It could also be because they have more aggressive treatment. Okay. Or they have better treatment. I don't know. But I'm going to guess that the bulk of it is because they pick things up earlier, and therefore we know early conditions are likely to get better outcomes.
All the papers that I've read very much seem to connect the dots between detection rather than the treatment aspect in terms of improved outcomes. So it's because they're detecting it earlier rather than that they have a super secret set of medicines that we don't have. But the breast cancer thing and the mammogram screening really kind of made me stop and think. And it's probably because I turned 40 this year. So I'm thinking, well, so now my question is, first off, do I need to change the advice that I'm providing to people in the sense of, in our clinic, we have a private practice, right? So should I then be telling people, women over the age of 40, you need to start thinking about your mammograms now, not in 10 years, you need to start thinking about mammograms now. And it's worth mentioning, this is for women with an average risk of breast cancer. So not someone who has a significant family history or not someone who has genetic conditions. But
so is there any specific advice for people who do have a family history? Are they meant to start even before 40?
So again, to refer back to the American Cancer Society guidance, they talk about women who have a lifetime risk of 20 to 25% and above, or those who have a confirmed genetic condition. So we talk about the BRCA1, BRCA2 genes. Those women actually from the age of 30 should be having a breast MRI and mammogram annually.
From the age of 30?
Age of 30.
I honestly can't say I've ever seen that in the UK for any patient.
No, but you and I both know patients who've had breast cancer in their 30s.
I've seen patients with breast cancer in their 20s. Statistically, it's much less likely. But statistics. There's always somebody who, unfortunately, gets it anyway.
I think when I started to look at the breast cancer screening guidance around the world, it definitely left me with a little bit of a quandary, kind of personally and professionally. It definitely made me think about the advice that I'm giving to women when they come for health checks, wellness checks, well woman checks, or just general discussions about their health.
So what would your advice be? For two groups, really, for sort of women with no specific risk factors, kind of an average risk, and then, you know, those people who do have a family history or something like that?
I think on the one hand, it is a little bit easier for me to answer that question because I do quite a lot of private practice. And in private practice, I have the ability to refer patients on to private scanning centers or for other kind of investigations. And in that circumstance, it's very easy for me to say to a patient, look, these are the numbers, these are the stats. If you are at a higher risk, this is what we would do in this country. This is the chances of you having cancer breast cancer. We should be looking at doing X, Y, Z. And I think actually from an NHS perspective, if someone had quite a high risk of breast cancer, I think we probably could link them into the breast clinic. I think that would be reasonable. But actually, if a woman has come to me who's 40 with an average lifetime risk of breast cancer, but wants to start breast cancer screening, again, I can answer that very straightforwardly in private practice and say, well, these are the stats. 16% of breast cancers are within your age range. That's not all the breast cancers. The risk is much higher as you get older, but we can look at privately referring you for breast cancer screening. But I also know that if I'm then back in NHS practice, even if there are stats that support early screening, I'm never going to be able to refer that patient. They're going to bounce that referral back. So it definitely feels, I definitely feel a bit troubled by how to balance that knowledge in terms of doing the right thing.
I think the important thing is letting people know what the ideal is. Okay. And ultimately, sometimes the system will cover it and sometimes the system won't cover it. So, having that knowledge, at least sort of kind of what your statistics are and what the ideal would be for you. And then it's up to you whether you are in any kind of position to actually get that screening yourself, or whether you do have to stick to the NHS guidance.
And then I guess the personal quandary then becomes, well, I've just turned 40. So does that mean that I should now start screening? So I should start now going for annual mammograms? And that definitely makes me feel a bit older, because I definitely wasn't prepared to start thinking about that at this stage. But, I'm not sure how in good faith I could go on without participating in a screening program.
I'll tell you another thing that surprised me was some of the rules for lung cancer screening. Again, something that I had no idea of until I read the American Cancer Guidelines. And essentially, if you are somebody with I think it's a 20-pack year history, which is, so a pack here, I think it's...
So it's smoking 20 cigarettes a day for a year is one pack year. So 20 cigarettes a day for 20 years. 20 cigarettes a day for 20 years is 20 pack years.
Okay. So if you have that kind of history, then you are meant to get yearly low dose CT scans. Okay.
From the age of about 50, I think.
Okay. Again, I've never seen that in this country. And we have hundreds of thousands of people that would fit that.
So in the UK, we have what's called the National Screening Committee. And in 2022, they made a recommendation that we should be proactively screening for lung cancer. And they've taken a slightly different approach. And again, this is the product of a public health service as opposed to a privately funded health service. But their approach is that we should be calling people over the age of about 50, 55 who have a 20-pack year history. Actually, I think the 20-pack year history comes from the UK guidance, not the American guidance. But a 20-pack year history should be called for a lung health assessment. If following that assessment, you're deemed to be high risk, then you'll be put forward for consideration of a low dose CT. But we are now 2 years on from that recommendation. It's quite telling that you and I didn't know anything about this as a program, because I was really shocked it even existed. But it does technically exist.
Okay.
In Wales, it exists as a very small pilot in South Wales, in a kind of a former mining kind of community where perhaps there may be a higher rate of smokers. So perhaps that's why they're doing the pilot there. It's very patchy across England. It doesn't exist in most of England. It doesn't exist at all in Scotland and Northern Ireland. And so there is technically a program that is starting, but it's really in its infancy in the UK. But I had no knowledge of it. And it only took looking into the guidance elsewhere in another part of the world to then reflect on our own guidance that I even heard about it.
So I think when you summarize all three conditions that we've looked at, breast cancer, prostate cancer, and lung cancer, then the ideals recommended in other countries are just not even contemplated in this country.
I mean, I think, as I said, this is the limitation of a public service where we have to consider cost. And that's the reality, isn't it? We have to consider the cost of these investigations and can we provide that service to everybody? But I feel like over the last year, as I've done more and more research on kind of health services in different countries, it's like almost like someone's pulled the rug from under my feet a little bit, because I've trained within the NHS, I've worked within the NHS, and those are the guidelines and the frameworks that are.
And we've always believed in those guidelines. We've always followed those guidelines.
In the thought process that we are doing best practice, right? That's what we're always trained to do, is always try and treat patients according to the latest best practice, evidence-based guidelines, and you provide care on that basis.
But we always follow NICE guidelines, okay, which is the National Institute for Clinical Excellence. But the truth is that is when they decide or determine whether something is appropriate to be funded by the NHS, then it is a cost-based decision.
Yeah.
So their aim is not to save the most lives. Their aim is to get the most bang for your buck. Okay.
While saving lives.
But that's the difference. You're not aiming to save everybody. You're aiming to save a reasonable number with a reasonable cost. So that's what we've been trained up on. But the reality, if you're really trying to give everybody the best chance, is different.
And I think actually a unrelated but a perfect example of how funding influences best practice within the UK is GLP-1. So Wegovy, Manjaro, Ozempic, et cetera, right? So we know what best practice, or we know what good practice might look like, but we also know the cost implication means that actually to qualify for that treatment on the NHS, you have to jump through 85 different hoops and be standing on one leg and basically have the other leg have been cut off because your diabetes is so bad.
My view on those is really clear. Okay. Having seen them in action and how well most people do on them, I would honestly be putting everybody on them who is overweight, because the incredible thing about GLP-1s in most people is that they just override all of the things that normally stop you from losing weight. Okay. Whether it be emotional issues or anything else. And they overcome it. And the vast majority of people will lose weight and lose a significant amount of weight. So if they did that, then by spending that money now, then they would find that the rates of diabetes would plummet. The rates of heart attacks would plummet. The rates of cancer would plummet. But they have no interest in doing that.
Obesity is a leading cause of cancer in this country.
And the only headline I read was something about it getting people back to work. Okay.
No,
it's absolute nonsense.
I mean, look, I know that it feels like in the last year, in our practice at least, because we are in private practice, that a lot of roads have led back to GLP-1 one way or another, right? But it does also feel like it's very hard to go more than a month without a new study or a new story. And I was reading, so I subscribe to Medscape, and I was reading a summary piece. Medscape have some useful stuff and they have some stuff that's clearly product placement, but I was reading a kind of a summary article about GLP-1s and their impact on various body systems. So it was talking about, the big trial that showed that even when obese patients were provided with GLP-1, even if they didn't lose weight, they had dramatically lower rates of cardiac, reduced rates of cardiac outcomes or cardiac events, sorry. It's also shown to be very beneficial to help treating non-alcoholic fatty liver disease. It's been shown to help with reduced rates of addiction. So people with drinking and things like that, those people, when they're taking GLP-1, seem to be drinking less. And it just feels, and that's not even to mention kind of the chronic kidney disease outcomes, the diabetes outcomes, the blood pressure outcomes. And you just feel like there just seems to be this building evidence that suggests that if someone has excess weight, this is potentially an option to really make a meaningful difference.
I guess the reality is that we are where we are.
Oh, sorry. One more thing I wanted to say about that, though, was that did you read the report about the Freedom of Information Act, about how many times they'd been prescribed in the UK?
I think it was pathetically low, wasn't it?
My gosh. So this is a Freedom of Information Act request. I think it was Sky News that put it through to all the bodies across England, specifically England. I don't think they covered Wales and Scotland. And they estimated that about 14 to 15,000 patients should have been eligible, based on NICE guidance, should have been eligible for treatment. And the number of prescriptions, not the number of patients, the number of prescriptions that had been issued from January through to May was 800.
That's pathetic.
Now, it's such a low percentage. Such a low percentage. So even when they are technically able to be prescribed, they're still not being prescribed.
So 800 over the course of 4 months, right? Which means that you're actually looking at about 200 patients compared to 15 or 16,000.
Yeah.
I have so many NHS patients that are gagging for this treatment.
Just for help. Do you know what I mean? And I
feel so powerless to help them.
Mm-hmm. I mean, people come to us in clinic and they usually have come because they've asked their GP. Actually, we've had a couple of patients who've been referred by their GP because their GP said, I just can't give it to you. And it's a shame because it's, those patients, once we have started their treatment, they're doing amazing.
I have patients now who have lost 40 or 50 kilograms in weight since last October, okay, which is as good, if not better, than surgery.
I mean, I think there was a trial in the US which was comparing outcomes with GLP-1 versus traditional bariatric surgery procedures. And they were, I'm not going to say they were always equivocal, but they were certainly in the same ballpark. Which is incredible because when you think about, my experience with dealing with patients with bariatric surgery is, as a primary care doctor, is actually generally dealing with the complications of bariatric surgery, in terms of difficulty maintaining weight or difficulty with medication, difficulty absorbing medication, difficulty absorbing, really key nutrients and vitamins, and then having to have replacement therapies. And that's generally my experience with bariatric surgery, with dealing with those patients. And I guess that's the interesting thing as the comparison between the two is you don't necessarily have as many of those issues. You definitely have some of them. We definitely have patients who on GLP-1s definitely need to be quite proactive with vitamin and mineral replacement. But, we don't necessarily have the same medication issues that we sometimes have with bariatric surgery.
So I think it's pretty clear that we are very passionate about proactive healthcare and health screening. But obviously in the summer, we saw a lot of people in peak physical condition. Obviously, we had the Olympics and I love the Olympics. It's one of my favorite sporting events. I definitely have to say that I saw some very, how do I put this? Very purple face swimmers. And some people with some amazing body transformations in a very short space of time. But maybe we'll talk about that in another video. But there were some good stories. What was your kind of favorite story from the Olympics?
What I like about the Olympics, I get so into it, even though I might know nothing about a particular sport. Give me about 15 minutes and I will become a qualified expert. So I always find every kind of Olympics, I seem to pick a new sport that I become mildly obsessed with.
It was Taekwondo last time.
I got really obsessed with Taekwondo last time. And I did watch quite a bit of Taekwondo this time, actually. There was a beautiful moment. We watched the match together where one guy was falling over and he still got chased and kicked by the other guy.
The guy kicked him in the bottom.
Yeah, it was brilliant.
It was the Korean guy who was chasing him.
Yeah,
kicked him in the bottom just to really emphasize that he'd won.
And while you're down, no. So yes, I did definitely watch some taekwondo this time. But I got weirdly into archery this time.
Yeah, we both watched that.
I just think the way the way the contest is done, you can kind of sit and watch an entire match, multiple rounds of a match within quite a short space of time.
It was like a whole afternoon, wasn't it? So essentially the opening round, second round, quarter, semi, final, all in that same block.
That session.
So people have to have multiple matches, but if you invest a few hours, you get to see the entire competition.
And I think that's what's quite nice, because often in the Olympics, especially if you think about the athletics, if you compare some of the athletics events, you've got like heat 1 to heat 8, and then you've got like the quarters, but they're spread out over multiple days. Whereas I quite like sitting down at the beginning, watching the start of the contest, seeing it all the way through to the conclusion, only within a couple of hours. But yes, I got very much into archery. I did wonder whether if I started now, could I become like a master archer? I don't know what.
No, you couldn't.
I don't know what it's called. But I really enjoyed watching the archery.
I've seen you try to throw something into a hoop. It's meant to be called a basket, but it definitely wasn't for you.
I mean, I was good at netball.
You tell me you were good at netball.
I was understandably, I was goalkeeper at netball because I was basically the height of the netball net, and all my...
That means you couldn't throw.
No, but I could block.
Yeah, exactly.
I was a lot taller than girls of my age generally, so I was basically just stand there and
you were chosen on the basis of physical size.
Yeah, like in hockey, I was defense in hockey as well.
Okay.
I played left back.
Yeah.
And the joke from my team members was that I was left back in the changing room. I thought was rude.
I tell you what I did enjoy though, was the triathlon.
We love the triathlon. We've watched it in successive games now, haven't we?
Yeah. What was the chap's name?
Alex Yee.
That's him. Yeah. And he did brilliantly. I always love a story whereby somebody is absolutely miles behind, no chance, a minute and a half behind, and they still come and steal it right at the end.
I think he's a very powerful runner. I mean, look, he's very powerful, obviously, in all aspects of the triathlon, but I think he's a particularly powerful runner. But I remember because he won gold in the previous Olympics, and obviously, so you have quite a lot of expectation that your national athlete is going to, we won gold last time, or we're going to do gold again. And I remember watching him kind of coming off the bike leg into the run leg, and you're just like, he's
about 45 minutes behind.
Yeah,
he's
no
not got
chance.
much of a chance.
But he powered through to gold again. So that was nice. But I also really like the mixed event at triathlon. That's what we quite enjoyed last time, which is when you have 2 men and 2 women in the triathlon in a team event, which I thought was quite cool.
I think my favorite 400 meter runner was another British athlete called Christina Ahorogu. And she did exactly the same thing as Alex Yee, in that she would be utterly pathetic for 3/4 of the race, be miles behind, 8th place, no chance, no hope. And then she would race past everybody. And with the last stride, she'd win the gold medal. And I think she did that twice. She
was a master at kind of, you'd watch her start and you'd be like, oh God, she's nowhere. And then literally you'd blink and she'd be powering through. Obviously, she must just have, was her style, right? She just had more power. She was a better finisher of the race, but it was quite stressful whenever you watched her. So that was the archery and triathlon. I love modern pentathlon as well, probably because it has the ponies in it as well. But I love the final run of the modern pentathlon when they have the run and the shoot, and because it completely changes during that. You have all the kind of the preceding events, and then if people miss their shooting in the final event, they just drop massively down the leaderboard. So it's quite fun to watch as a spectator.
And you quite like all the equestrian events in general.
Yeah. So I Yeah, I do. I didn't watch much of the dressage this year because there was that controversy immediately before the Olympics where kind of one of our leading riders was kind of dropped from the team. So I didn't really watch a lot of the dressage this year. But I watched the show jumping and the eventing. I watched quite a lot of. So what was really nice is in London 2012, we had a team of people, and 2 of those team members were on our team this time round. And the third team member then was the father of the guy who made up the third team member this time round.
Oh, great. Okay.
So it was a kind of a family story.
Yeah.
But that was quite nail biting, the finish of the jumping, but that was quite fun.
Yeah. So I think the Olympics, sporting a highlight of the year, and
well, it wasn't the Anthony Joshua fight. That wasn't a highlight of anyone's year.
That was a total disaster. And I think unfortunately, as much as I love AJ, I think he's kind of in trouble here. He has to come back and somehow beat Dubois. I didn't think Dubois had a chance, actually, because Dubois has previously been beaten also.
Mm-hmm.
So I'm really hoping that Joshua can come back and do something.
I actually, we were watching the fight, and not there. We were here watching it, and I actually got up and walked off because I couldn't watch it because
it was the 3rd or 4th time we've seen Joshua take a beating.
Yeah, and I think the thing about AJ is that I find quite, and I understand it, but if you watch his kind of Olympic fights and his kind of pre or very early professional fights, but certainly before he turned pro, he was just a different fighter.
He was better before the training. So he was better when he was raw and he hadn't had years and years and years of people telling him that you need to do this and you need to do that.
Like
when he just got in there,
if he sensed blood, like he went in
and he would just destroy the guy.
And he'd finish it and it would be done.
And he's lost that killer instinct.
But you just don't see it anymore in him.
No.
And I don't think we've seen it probably since the
since Klitschko.
The Klitschko fight.
Yeah. Because he's had something to lose.
Yeah.
Since then.
Yeah. And I was definitely I just couldn't watch the rest of that fight.
Yeah.
And obviously now coming up we've got Fury Usyk.
Yeah.
Again.
Which Usyk will win.
How many times has this fight happened now?
This is just the second one, but Usyk will win this.
Is it only the second? It feels like the third.
This is genuinely only the second one.
The thing I really liked was I loved when Usyk asked Fury to sign a picture
of him getting beaten
up. Although you showed me a video the other day of Usyk and
Usyk beat Bellew up.
Yeah.
I think he beat Hay up. He beat AJ up. He has essentially beaten everybody up. And I remember not really paying attention to this guy. Mm-hmm. And when Joshua fought him, being really shocked that Usyk had won. Mm-hmm. But when you really look through his career,
his pedigree,
he is the best.
Yeah.
Okay.
So Usyk will win this fight.
Usyk will win this fight.
Right. Okay.
And at that point, Usyk just has to fight Dubois, get his other title back, and then quit.
Then
quit
done.
top.
Yeah.
Yeah.
When is that fight? Do you know?
Usyk Fury is very soon.
Okay.
Actually.
Speaking of other fights and rematchups, we will shortly know who will be the next president of the US.
Oh yeah, by the time of our next episode, we will know who the next president is. And I can't call it at the moment.
There's been a new poll, hasn't there, that's put Harris marginally ahead in some states, key states, right? I think.
All I know is that I'll be disappointed whoever wins. It's that bad. At least it's not Biden, but I'm not enamored with either candidate.
I think it's about choosing the least worst option
and riding it out for 4 years.
I think that's my gut impression.
I think for me, whoever is going to actively bring these wars in the world to an end, that is what matters to me more than anything else.
Yeah, I think I don't know. I know from my own personal, I guess, ideology, I know who I would normally align with.
Yeah.
But I wouldn't want to be voting in this. Like, it feels a tough sell.
I think it's a tough one. Yeah.
But however, that being said, even if I don't particularly like either candidate, I do love an American election.
Oh, the razzmatazz is brilliant.
I mean, I've seen some of like the stages that they've had, and like it's just so alien to us. Like we would never have a rally or anything like of that kind of nature. Do you know what I mean? But
it's a proper show.
It's a real show. Yeah. But I also quite enjoy watching it on streaming the results. Yeah. There's a key race alert, but it isn't really a key race alert. Yeah,
some tiny town has announced
breaking news, and you're like, oh my god, how many days did we watch the last result over?
So in our next episode, we will talk about who's won the election, possibly, depending on how contested it is.
Yes.
And I think we're also going to talk about sport and the use of supplementation in sport.
PEDs,
exactly. So we'll see you next time.
See you in the next one.